Tout ça, celui-là. Okay. It's time to start the presentation. We are a little bit late on weaning. My name is Arnaud Thiel. I work at the University Hospital of Poitiers in France.
I'm Lise Piquiou. I work in Lausanne, Switzerland.
You have the French accent for both. Okay.
And let's start. My strategy for weaning. Then we also need your strategies. Then we are going to start with a short clinical case. Sorry, where is my patient? Here. 75 years old, previously healthy. He was intubated because of severe pneumonia 15 days ago. And now he's doing better. He's now hemodynamically stable with only a very low dose of noradrenaline. He has no fever anymore. He is lightly sedated with propofol. The RAS score is at -1. And he was switched to pressure support yesterday afternoon by the colleagues. And in the morning, when you do the clinical round, you have a patient under pressure support ventilation with a pressure support level of 16, a PEEP of 12, a FiO2 of 40%, a tidal volume measured of 550 milliliter, respiratory rate of 20 by minutes, and no evident respiratory distress. And my first question for all of you is it time for a SBT, spontaneous breathing trial? And we have 3 possible answers. A, yes. B, no. C, I don't know.
I asked
Information is missing.
A friend. I asked to another clinician in the unit.
Yeah, this is the D. Then, who is for A? Some of you. Who is for B? Half-half about. Who is for C? And who asked the friend? Or the boss? Nobody. Okay. Then maybe you would like to comment? Why?
Maybe we can analyze each item. 75 years old, okay. Intubated for a prolonged period, 2 weeks, probably at high risk of extubation failure. And duration of mechanical ventilation above 7 days is a clear risk factor for extubation failure. Hemodynamics stable with a low doses of noradrenaline. All guidelines recommended to perform a spontaneous breathing trial after a complete weaning of noradrenaline, but we know that we can do a spontaneous breathing trial with low doses, and we have a very interesting paper published last year, and with we can hasten weaning without risk of extubation failure with low doses. But be careful, in this study, they found that above 0.1, they observed an increased risk of reintubation. Therefore, probably we can do it with very low doses of noradrenaline. Lightly sedated with propofol, with a RAS of -1. It's very interesting because in all guidelines also, they suggest to stop sedation, and in other, we have a RAS scale. When we started our clinical trial comparing different spontaneous breathing trials, we proposed RAS score between -2 or 0 without sedation. And therefore, when we started the study, many centers told, if we have a little of dexmedetomidine or propofol, low doses, etc., etc. And then, during the study, we changed the protocol to propose as weaning criteria only the scale without, regardless, the dose of sedation. But I don't have the data to know how many patients had actually low dose of sedation. Switch to pressure support, okay. Pressure support 16, it's a little bit high, but the level of pressure support is never included in weaning criteria. Why? Because it could be due to low compliance, increased severity, but also because the clinician adjusted too high pressure support level. And for example, these patients with a tidal volume of more than 500 milliliters maybe receive a too high pressure support level, and therefore the level of pressure support is not included in weaning criteria. Obviously, in general, in overall, patients with high pressure support level have probably more respiratory severity than the others, but it's not included in criteria. PIP 12 is probably, in my opinion, the more important problem for these patients, because in all studies, all guidelines, they recommended a PIP level of 5, and then PIP 8, and in recent Spanish studies, PIP 10, but never we had this high level of PIP at time of initiating first spontaneous breathing trial. And therefore, respiratory rate is relatively low, maybe too low, I don't know why. Respiratory, yes, 22, 25 after 2 weeks of mechanical ventilation. In these patients, if I'm the clinician, I do the round for the morning, I prefer to stop sedation and to decrease PIP at 8 and do a new round for the afternoon. If the patient is very good, maybe, and probably I could add an cuff leak test to be sure that there is no leaks, and but I would wait a little bit, especially because also this patient is a patient at very high risk of extubation failure.
And I agree 100% with what was said, and would like to underline one thing. It's very important to be proactive with weaning. Then even if right now, this patient cannot do safely a spontaneous breathing trial, it is possible that you can have all the criteria in some hours. Then here, you must be proactive, probably reducing sedation, reducing or at least trying to reduce PIP level, and then you are going to have your criteria. And the second point is the point about over-assist. Over-assist is very frequent in our units. An over-assisted patient is sometimes not so uncomfortable. It's easy not to see over-assist. Then we should never say, I don't try because my patient has 16. We can try to reduce, of course, also avoiding under-assist, which is also not good, but be proactive. Do you agree? Yeah. Yeah. Then this was the
Any question now about the case, or probably you have maybe other opinion or comments? No? Or?
I agree.
Okay.
And we can go to the next question. And the next
problem,
question,
another problem is maybe you can examine this patient at 9 or at 12 during your round. If he's the last patient of your round, this is a problem of weaning. If maybe you will see these patients at 9 or at 12. It's completely different, because time to reduce sedation, to reduce pressure support, to reduce PIP, and it's tomorrow. And
you've possibly seen the very recent paper from Karen Burns in the JAMA that tested several times a day versus 1 time a day. Several times seems to be even worse than 1 time a day in this specific paper. But here we don't say that we should do several SBT every day. We say that we should be proactive in all the things that can give you the criteria to do the SBT. It's not the same. And which SBT? Big question. A T-tube. B, pressure support level 8 of pressure support, 0 of PIP. C, pressure support 5 of pressure support level, 5 of PIP. D, pressure support but 0 pressure support level and 0 PEEP and something else. Who is for 1? T-tube. 2, 2, 2, 3, 3, 3.
Don't hesitate to. There is no wrong response, maybe, but no.
Definitely not for that, I think. Then who is for B? 8, 0. Some, not so many. C, 5, 5. The vast majority. D, 0, 0. This is something that was recently described by the French team because this mimics the respiratory effort just after extubation. And something else, maybe CPAP. Yeah, some for something else. Then the vast majority is for C. What do you think? Which one would you like to choose?
It's very interesting. In the study published by Karen Burns on weaning practices, it's true that a pressure support level with PEEP was the most frequent spontaneous breathing trial. But difficult to know, it was different according to the country. And more frequent, T-tube was more frequent in Europe, but it seems not to be the case. Pressure support ventilation was more frequent in US, Australia, etc., and more frequently with PEEP. And 0, no, it's very not so frequent. What can we? It's true that the main objective is to mimic post-extubation condition, and to mimic post-extubation condition, T-tube is the best trial. This is exactly the same walk of breathing during your TPs and after extubation. Why? Because it remains a high level of resistance, of upper airway resistance, and therefore walk of breathing does not decrease immediately after extubation. And therefore walk of breathing is the same after extubation and during the T-tube. Pressure support level 8 was suggested by my mentor, Laurent Brochard. We worked together in Paris 20 years ago. And when they performed physiological studies in 90s, 35 years ago, they found with all ventilators that a pressure support of 8 allowed to compensate walk of breathing due to endotracheal tube, valve, trigger, etc., etc. And therefore, it was proposed to simulate a T-tube. But with improvement of new generation ventilators, recent trials found that obviously walk of breathing during a pressure support ventilation trial is significantly and markedly lower than during a TPS. But the first studies comparing T-tube and pressure support ventilation was performed in Spain. The first one by Esteban in 30 years ago. They compared both. And they found that the first spontaneous breathing trial was more frequently a success with pressure support, according to the physiological data. But the proportion of patients extubated after one spontaneous breathing trial and not intubated was the same, a trend for pressure support, but it was not significant, and the two types of spontaneous breathing trials were considered as equivalent. But Carles Subira performed a very, very important study in 2019. They compared a very hard trial, T-tube, and a very easy trial, T-tube 2 hours, pressure support 30 minutes. And they found that, again, a higher proportion of patients succeeded the first spontaneous breathing trial, according to physiological data. This is an easier trial than a T-tube trial. And they found that reintubation rates were exactly the same. And therefore, the proportion of patients with simple weaning without reintubation was higher with a pressure support level 8 without PEEP. Okay? And therefore, whereas it's not the best trial to simulate, replicate post-extubation condition, this is the best trial to extubate rapidly without increased risk of reintubation. We did a second study in patients at high risk of extubation failure, 1,000 patients, and we found more or less the same. A higher proportion of patients, even in patients at high risk, succeeded this trial without increased risk of reintubation. Therefore, probably, in my opinion, pressure support ventilation 8 without PEEP would be the standard care actually. But in reality, most of clinicians use pressure support, I don't know, 5 or another level, and PEEP. And PEEP further decreases work of breathing. So we don't have many data for that. Recent study published in Annals of Intensive Care in patients who failed the first spontaneous breathing trial, and between T-tube and pressure support 8 PEEP5, they did not find any difference in terms of reintubation, but a small-scale trial. And therefore, I think we don't have many data to support the use of a pressure support level with PEEP, which is a spontaneous breathing trial, very easy. But maybe it's the best way to hasten weaning, to reduce time to extubation without increased risk of reintubation. But we don't have many data for that. I'm a little bit long. I'm very sorry. No. Okay.
Maybe just to add something, I agree. For me also, this is currently the one we use in the unit. That is in the protocol. And also for another reason. As said, right now, we don't really know whether B is better than C or C is better than B. But this one has an advantage. I like systematic approach of weaning because this has been demonstrated to hasten mechanical ventilation liberation. And if you do this one, at least it's very clear every morning that you do an SBT, because someone is going to change the ventilator setting to do the SBT. And this is a clear advantage, and this is right now the only reason why I choose this one in our weaning protocol. And maybe also last thing about practical things. You probably have observed that in some ventilator you cannot put 0 but only 1, because basically all the ventilator always deliver 1, but some of them don't tell you. And basically it's 1 because of the flow by. And the last thing about that, we were asked this morning whether we should use automatic tube compensation. We can, but if you use automatic tube compensation, do not add 8 in addition, because if you do that, you have not SBT. This is just the only thing to be careful.
When you use automatic tube compensation, work of breathing is lower than T-tube, but higher than pressure support 8, and it's in the middle. I would like to conduct a new study, maybe with to test pressure support 8 with PEEP5 versus pressure support 8 without PEEP. And Carles, you have a study ongoing, no? On this topic, and I think it's very interesting. And maybe we could further hasten weaning extubation anymore with an easier trial with pressure support and PEEP, like you do in the majority of clinicians here.
Imagine that this patient has gone his SBT, was successful without any discussion, perfect at the end of the 30-minute SBT. Now, have you got other criteria to extubate? I'm very interested in having your opinion about that. SBT is perfect.
A good cough.
A good cough. Something else?
How to assess cough?
A cough, yeah. Enough strength to have really an efficient cough. Something else? What about secretion and aspiration in the tube? Does someone look at that or not? Yes? Yes, I see some saying yes. And maybe we can comment. What are your criteria to extubate this patient?
I think cough is more important than secretions. Cough is difficult to assess or to integrate in the decision, but it's clearly a major risk factor for extubation failure, the most important factor, meaning that patients extubated with weak cough have reintubation rates above 30%, 35% in all studies, and as compared to the usual 15%. It's very rarely a risk factor important. To assess cough, a recent meta-analysis very interesting. You can assess cough with peak expiratory flow. The problem is that the thresholds are different from another study to another, or using a semi-quantitative scale. For example, ineffective, absent, ineffective, moderate, effective, very effective, etc. And it does work perfectly. And in both, you separate patients with weak cough with an increased risk of reintubation and the others. The main problem in this patient, 75 years old, maybe we stop sedation, is okay, perfect, etc. Cough is weak. What can we do? If you did not perform tracheostomy before, but I think despite a risk of 30 or 35%, it's probably, in my opinion, time to extubate, except if you are waiting for a rapid, quick improvement, for example, due to sedation, because he had still sedation, and maybe tomorrow or within the next 48 hours after stopping sedation, etc., he will be better in terms of cough. But if it's not the case, I think I take the decision to extubate the patient despite weak cough. In a larger cohort that we have, weak cough is it is not so frequent. We remember these patients because often they have prolonged duration of mechanical ventilation and sometimes reintubation, etc., etc. But in our patients with patients at high risk of extubation failure, less than 10% of patients were extubated with weak cough. Again, with a risk of reintubation rate around 30%. But if you are not waiting for a quick improvement, in my opinion, I take the decision to extubate the patient and to apply different prophylactic non-invasive ventilatory support to avoid reintubation.
And when you really don't know, very practical tip, ask everyone who takes care of the patient. If the nurse says no chance, if the physiotherapist says no chance, if the colleague says no chance, you probably have no chance. It's very practical, but it's quite efficient.
And do you think that we have to assess cough and secretions before or after SVT? Because if you are not planning to extubate the patient, maybe it's not necessary to perform an SVT.
I think after.
Me too.
Because you may have the information of spontaneous breathing trial failure and to analyze the reason, pulmonary edema, etc. And I think a spontaneous breathing trial failure is a very good information to improve, to decide treatments, to be proactive.
Clearly, and to succeed next day, probably. Then definitely yes, after. Then now, this patient has been extubated. And the next question is which respiratory support after extubation for this patient? 75 years old, no comorbidities. A, high flow, B, NIV, C, CPAP, D, low flow oxygen. Who is for A? About, I would say, 20% of the room. For B, higher, less, interestingly. CPAP, some, and low flow. Nothing, basically. Some of you also. Then very different answers. What would you say?
I use non-invasive ventilation in this patient. I think I have a bias because I have intellectual conflict of interest, but we have data enough to showing that in these patients, non-invasive ventilation is effective to reduce the risk of reintubation. The first studies started 20 years ago by Stefano Nava and in Spain, Miquel Ferrer, with decreased reduction in small-scale randomized controlled trials. And after these studies, a few clinicians used non-invasive ventilation in clinical practice. But we have new data. We performed a study 5 years ago showing a decreased risk of reintubation in patients at high risk, meaning an age of more than 65, underlying chronic respiratory disease or cardiac disease. It's not the case of this patient, but he's aged. And Gonzalo Hernandez in Spain showed also that patients cumulating several risk factors, for example, this patient age, prolonged duration of mechanical ventilation, probably weak cough, etc., and probably another comorbidity, or I don't know, but he found also a decreased risk of reintubation as compared with high flow nasal oxygen. And therefore, I think we have data enough because before these two studies, guidelines already suggested the use of NIV in patients at high risk of extubation failure. Guidelines performed before 2000s. And therefore, we have these two new studies, and you don't have studies showing deleterious effects. And in these two studies, the risk of reintubation, which is probably the main patient-centered outcome during the weaning period, showed decreased risk, significant decreased risk. And in my opinion, these patients may benefit from non-invasive ventilation.
I clearly also agree because of the recent studies especially, but again, there is something that is very practical. If you decide to use NIV as a prophylactic technique after extubation, really use NIV. That means it's not 30 minutes once. It's shortly after extubation first, and it's for enough time. And basically in the different studies, it's at least 8 to 10 hours a day. It's a lot. And if you don't do that, maybe you can at least use high flow. It's probably a bit less efficient, but it's better than nothing in patients at risk.
But we have a good tolerance because in our study, for example, in 600 patients, half treated with non-invasive ventilation, we encouraged to have more than 12 hours a day of non-invasive ventilation, and only 5% of patients had poor tolerance, and it was relatively easy to promote a prolonged duration of sleep, of non-invasive ventilation, and especially during the night. And if the patient is sleeping with non-invasive ventilation, we continued non-invasive ventilation, and we obtained relative prolonged period of non-invasive ventilation.
And in addition, it's an easy-to-set NIV, I would say. Some PEEP, some pressure support, and by default parameter of your ventilator. In this situation, usually it works. Also, probably a very important practical aspect.
Just a question, if it's a concern to you if the patient has a lot of secretions, like if he or she has to cough up quite frequently and you have to take off the mask to do so.
Between NIV sessions in our unit you use, and in the protocol we use high flow nasal oxygen, and therefore you can alternate non-invasive ventilation and high flow nasal oxygen. And probably we need a respiratory therapist and maybe a cough assist, maybe. But you're right, it could be a problem, but in a minority of patients, it's.
And definitely high flow between the NIV session is a good way to manage secretion. It really works. Then maybe a last question, because we are already at the end. Yes, over there.
It was actually, the question was related to the previous question. Do you regularly perform cough leak test by by different patients who are going to be extubated?
It's a very, very difficult topic. We know that steroids can decrease stridor and can decrease the risk of reintubation. But in previous studies, steroids were administered for long periods of 12 hours, and the risk is to delay extubation. Therefore, in our unit, we perform a cough leak test in all patients, but you can choose to do in only patients at high risk, for example, women, a prolonged duration of mechanical ventilation, etc., traumatic intubation. I think the most important is to choose a strategy. Regardless of the strategy, to have the same homogeneous strategy in your unit. And therefore, in my unit, we perform a cough leak test, systematic cough leak test. And in case of no leaks, we delayed extubation by 6 hours after one administration of methylprednisolone, 1 milligram per kilogram. And as we have a protocol driven by nurses and initiating a first spontaneous breathing trial early during the morning, we can extubate this patient during the afternoon and not one day after. But it's our strategy. I don't know if it's the best, or we choose all patients, cough leak test, and only steroids in patients with no leaks.
Yeah, we do nearly the same. And for sure, patients who are at high risk of stridor could benefit from the test with a small risk of delaying extubation, I agree. And we have the chance to have ENT colleagues who come quite early in the unit. Then before giving the steroids, we ask for the exam. But I know that it's not everywhere like that.
Thank you. If I get the honor to ask the final question. What about a patient that fails an SBT, but has all of the criteria sort of on point? Sedation's fine, secretion's fine, cough is fine. How about we put that patient on a certain level of PEEP and a certain level of pressure support that can be copied non-invasively, and then extubate and copy those settings in a non-invasive way? Is that a strategy that's sort of acceptable or not at all?
It's a very large question. First, are you sure there is no another reason for SBT failure except cough, etc., etc.? Cardiogenic.
Let's say so it's a hypothetical scenario.
Okay.
But let's say it's obese patient that needs some PEEP and some residual pneumonia or something.
We have studies showing that mainly in COPD patients, we can do the transition to non-invasive ventilation with the same settings. Patients were very selected. We have an English study, Perkins, for example. They extubated the patients after spontaneous breathing trial failure. But in the study, they observed a trend for an increased risk of reintubation. And this strategy first should not be increase the risk of reintubation. And in this study, it's not really demonstrated because there is a 10% of difference. And therefore, mainly in COPD patients or patients with chronic lung disease, it's possible to do that without you are in the best conditions, without cough, without cardiogenic pulmonary edema. It's possible to do it, but it depends on the reason for spontaneous breathing trial. If patient sees respiratory rate is 45, I do that, but twice or a year, but mainly in patients with hypoxemia, not in patients with respiratory distress, because I know that after extubation, I can provide more oxygen with high flow, with non-invasive ventilation, with FiO2, but I'm not so confident in case of real respiratory distress and a very high respiratory rate if this is the cause of a spontaneous breathing trial failure.
I'm also very careful with this situation, except in COPD. Those ones, I think definitely we can, as long as you can really deliver efficient NIV after. And this one, it's not easy to set an IV.
Is there time for one more? What's an optimal reintubation rate? Like is 10% reintubation, is that ideal? If you're aiming for 0% reintubation, then probably you're keeping everybody on a tube. Yeah, reintubation. So failure of extubation. What's an optimal number your unit should aim for? If you have 0% or 1% need for reintubation after extubation, then you're keeping everybody on a tube.
Impossible to have 0%.
No, so is 10% the goal? Like if some centers use really easy SBT so that many patients pass and then they're extubated easily, and then I don't know what you're.
No, you're right. It's a good question. It depends also the patients admitted in your units and many things. But okay, but it's difficult to extubate systematically patients who failed the spontaneous breathing trial and to have increased risk of reintubation or rates around 30-40%. For example, in the study by Perkins, I think the rate was, in my opinion, not acceptable. 38%. It's not possible to have so high rate. And therefore, you have to compare for the literature. Depends on patients. Postoperative is easier than medical patients with immunocompromised, etc. Patients with respiratory disorders, and but regardless the rate, we have option to decrease the risk, NIV, etc. And it's interesting to apply these strategies regardless the risk in your unit.
What about the patient who had already tracheotomy? How do you do it then?
It's another weaning of tracheostomy. It's 1 hour of discussion. No, it cannot be the last question. It's not possible. No. Sorry.
I'm just curious. It's taking the cue from one of the demonstration from today. That's with the EITs. Can we take this tool as a kind of tool? No. I mean, the kind of demo they were showing.
Research to understand mechanisms, etc. And we perform, for example, we measure with impedancemetry and expiratory lung volume to assess loss of lung volume after spontaneous breathing trial, but only for research and not for a clinical practice.
Promising technique, but no data. And maybe one thing, an additional thing about the rate of reintubation. Definitely we don't know what is the good rate. 0% for sure not. But how much, I don't know. But what you can do in your own unit is looking at what happens to the patient with self-extubation. If you have 0% of reintubation after self-extubation, I'm sure you are too late. And we had something like that. It was not 0%, but very low in the past, before introducing a weaning protocol in our unit. And after the introduction of the weaning protocol, our patients who were self-extubated had a much increased rate of reintubation, which I think is a good news.
We conclude?
Yes? Then thanks a lot. Thanks a lot, Arnaud. Thanks to everyone for your participation.